Good evening and welcome to this non-CME educational program entitled Chronic Inflammatory Airway Diseases, Expert Insights on Unifying Management Paradigms. We are honored to have participants from across the country in attendance, not only in this room, but also viewing online. A few important housekeeping notes for those of you in the room. This program is provided by Integritas Communications and supported by an educational grant from AstraZeneca. To answer polling questions, please use the keypad provided. Your responses are anonymous and very important to the outcomes of this program. The information being presented is available online. The link is listed on the card in front of you. This card also provides links to valuable clinical resources, educational activities, and patient testimonials. As part of our ongoing efforts to evaluate impact and refine future activities, please complete and return the evaluation form before you leave. For everyone joining us online, the system will prompt you to answer polling questions, and the information presented is located on the right side of your screen under the Handouts tab. The evaluation will automatically open in your web browser following the conclusion of the program. Now, let's give a warm welcome to tonight's presenters. Dr. Flavia Hoyt,
Woo!
Dr. Stella Lee,
Woo!
and Dr. Michael Wexler.
Boo!
Enjoy the program.
Well, thank you everyone for being here tonight. Today we are going to talk about chronic inflammatory airway disease with a focus on the unified airway, so really a multidisciplinary approach to treating the diseases of the airways. Here are our disclosures and our educational objectives. So these are also in your program, but we're going to look at pathophysiology tonight, talking about chronic inflammation, hyperresponsiveness, and remodeling in the upper and lower airway and how that might impact treatment. We're also going to discuss some clinical profiles and evidence behind the biologic therapies to help address overactive cytokine signaling, and then tailoring biologic-based therapies for patients with severe asthma, allergies, and chronic rhinosinusitis with nasal polyps to help account for underlying disease processes and overcome treatment-related barriers. So if you have your audience response systems ready, we're going to start with some pretest questions. The answers will not be shown, and then keep using the system throughout the program, and then later you will see some answers. So first question, approximately how many patients with severe asthma do you manage each week? Answer 1 is 1 to 5, 2 is 6 to 10, 3 is 11 to 15, and 4 is greater than 15. 5 is I do not manage patients with severe asthma. Okay, pretest question number 2. Approximately how many patients with both asthma and chronic rhinosinusitis with nasal polyps do you manage each week? Same answer choices here, so 1 through 5, 6 through 10, 11 through 15, greater than 15, or I do not manage patients with both asthma and chronic rhinosinusitis with nasal polyps. Okay, pretest question 3. Which of the following plays a key role in orchestrating the upstream activation of both T2 high and T2 low or non-T2 inflammatory pathways in upper and lower chronic inflammatory airway disease? Number 1, TSLP. Number 2, interferon gamma. Number 3, IL-17. And number 4, IgE. Okay, pretest question 4. So based on the EPOS Euphoria 2023 criteria, which of the following scenarios would indicate that a patient with CRS and nasal polyps who has bilateral nasal polyp recurrence after surgery may benefit from implementation of a biologic therapy? 1, a FeNO of greater than or equal to 20 parts per billion. 2, a SNOT-22 score of greater than or equal to 30. 3, presence of comorbid asthma with occasional ICS use. Or 4, daily low-dose OCS use for the past 3 months. Okay, pretest question 5. So here's a case. Jane is a 35-year-old woman with a 15-year history of T2 high asthma and 10-year history of CRS with nasal polyps. Although her CRS with nasal polyps symptoms are well controlled, she continues to struggle with uncontrolled severe asthma symptoms despite continuous low-dose OCS, along with an ICS LABA/LAMA. What would you recommend for Jane at this time? A sinus surgery, CT of the chest to assess mucus plugging, refer for bronchial thermoplasty, or increase in OCS dose? Okay, and our last pretest question. Approximately how often do you currently consider the presence of comorbid chronic inflammatory airway disease, i.e. allergic rhinitis or CRS with nasal polyps, when choosing a biologic therapy for patients with severe asthma? 1, never. 2, 25% of the time. 3, 50% of the time. 4, 75% of the time. 5, 100% of the time. And 6, I do not manage patients with severe asthma, CRS with nasal polyps, or allergic rhinitis. Okay, perfect. Well, let's move on then. We're going to talk about the Unified Airway model. And so we'll start with kind of what it means. The Unified Airway model is actually a concept that's been around for many years. And it really talks about the upper and lower airway disease reflecting a single pathologic process that's manifesting in these different locations. And we think of the glottis as kind of the artificial division between the upper airway and lower airway. So upper airway, we think of the nose and the sinuses and the oropharynx. And then lower airway, of course, is the trachea, the bronchi, bronchioles, down to the alveoli where the gas exchange takes place. And if you think about the different pathologies that occur in these two different regions, in the upper airway, we have allergic rhinitis and CRS with nasal polyps, which we'll spend the bulk of our night talking about, but also CRS without nasal polyps, and then non-allergic rhinitis, mixed rhinitis. Otitis media is not actually a disease of the upper airway, but it is a comorbidity with these conditions. And then in the lower airway, we have asthma and eosinophilic COPD. AERD, or NSAID-induced exacerbated respiratory disease, is sort of the iconic unified airway. So you have the chronic sinusitis with nasal polyps, and you've got the eosinophilic asthma and also aspirin sensitivity. So that's Samter's triad that really does bridge both of the airways. And we know there's bidirectional provocation with allergens, but also other irritants and other infectious triggers really do tend to impact both the upper airway and the lower airway. And although there are a lot of similarities, we also know that there are differences between the airways. And so, that's the goal tonight, is really to talk about the similarities, the differences, and how that might impact our therapy. So supporting evidence for the unified airway theory really comes from epidemiology and also from pathophysiology. So in terms of epidemiologic evidence, we know that in patients with CRS and nasal polyps, up to about 70% of them have comorbid asthma. And the reverse is true. So in patients with asthma, we know that 40% have comorbid CRS with nasal polyps. And then in terms of pathophysiology, so the bulk of the CRS with nasal polyps that we see in this country is really the type 2 inflammation. And that's also true with asthma. And so we see the eosinophil as a prominent player, and then the cytokines IL-4, IL-5, and IL-13, very important in both conditions. And then in terms of cell types, so we know that both the upper and lower airway have ciliated epithelium and goblet cells that help produce mucus, and that is pivotal to both the upper and lower airway inflammation. And then the type 2 inflammatory cells and type 1 inflammatory cells shown here are relevant for both the upper and lower airway. So how important are these conditions? Well, we know that allergic rhinitis is a very common condition, so it affects 25 to 40% of individuals worldwide, and it's considered the 5th most common chronic disease in the US. Although it's not life-threatening, so we don't talk about mortality, we talk about lost productivity. So $2 to $4 billion lost annually in productivity. Similarly with CRS, not as common, but still common, 5 to 12% of individuals in the US. And of those patients, 33 to 50% have concomitant nasal polyps. Lost productivity is estimated to be about $10,000 annually per patient with refractory disease. And then asthma, also very common. So greater than 25 million individuals in the US are affected. And depending on the source, about 5 to 15% of these patients have severe asthma, which results in millions of emergency visits every year. So these are three conditions with a lot of impact. And when we think about how the diseases talk to one another, allergic rhinitis and CRS, when you talk about patients with CRS, about 40% of them have preceding allergic rhinitis. If you're talking about asthma and CRS, you know, as we mentioned, 40 to 70% of patients have both. And the greater the asthma severity, the worse the nasal polyps and the chronic sinusitis, and vice versa. And then when we're talking about allergies and asthma, the same is true. So approximately 80% of patients with asthma have concurrent rhinitis. And then those patients who have allergies tend to have more emergency department visits and also more asthma attacks. So not only do these conditions go together, but they also portend a worse outcome. So in summary of our introduction here, patients with comorbid upper and lower airway disease have higher rates of nasal polyp recurrence and corticosteroid dependence. They have more difficult to treat asthma and CRS with nasal polyp symptoms. They're more prone to asthma exacerbations, and they have worse outcomes overall than patients who only have either upper or lower airway disease. So now we'll hear from a patient named Amanda, who has a long history of both severe asthma and CRS with nasal polyps.
When the asthma diagnosis first came, the physician that I was working with, their first line of defense was to try oral corticosteroids. Unfortunately, that seemed to be the only line of defense for about 4 years. I was continuously on oral corticosteroids. I was told they would work wonderfully to control the symptoms, they would help with the inflammation, I would feel so much better, and all of that was true, but it wasn't explained to me that, you know, that they're detrimental, that it suppresses your immune system and that it can have long-term effects. I definitely think I wouldn't have been as eager to take the steroids if I had realized the long-term, you know, damaging effects. It definitely in the short term affected my appetite, affected my sleep. You know, I even started to get they call it a moon face, where, you know, the weight gain was distributed in that way. So I definitely think that that's something patients should be made aware of before they start taking that medication. I've been told by my eye doctor that I have signs of cataracts. I'll be 50 tomorrow, and so it's early, and he said that that's from long-term steroid use. In addition, when I had my daughter, which was 11 years ago, they had to give me IV steroids prior to delivery because they were afraid of how my immune system would respond. Other than that, I seem to have returned to normal. I don't have any other, thank gosh, lasting effects. But again, definitely things that I didn't take into account. So about 4 or 5 years into my asthma diagnosis, my pulmonologist decided that we would try biologics. And the first biologic, it worked great at controlling the asthma, and it worked for several years. And I didn't realize that I may at some point have to change medications. I didn't realize that the medication may stop working at some point. And I found that out when that's what happened. I started to have asthma flare-ups that required prednisone use. And at that point, my physician recommended we try another biologic. We tried that. It worked wonderfully for the asthma. However, it did not help control the sinusitis. So at that point, we made a switch to the third biologic, which is what I'm currently on. I've been on it for about 5 or 6 months. And this biologic has worked wonderfully to combat both the asthma and the sinusitis. When I was told that I needed sinus surgery to remove the polyps, it wasn't explained to me that the potential for recurrence was there. I thought that I would just have a single surgery, remove the polyps, and that would eliminate the issue. That wasn't the case. I had to have 2 subsequent surgeries for a total of 3 to remove the polyps. And I now realize that the potential for another surgery is there. I think it's very important for physicians when they're working with patients that have asthma and chronic sinusitis that there be transparency. I think a physician needs to let their patient know that we're going to try a course of treatment. This may work, this may not work. This may work for a short time, and then you may find that we need to switch. I definitely think that for me, I would have had a more realistic expectation of my course of treatment. I think it was a surprise to me when that the first biologic plateaued, and I wasn't finding the same response that I was getting before. So I think transparency is definitely important. And on the flip side, I think it's important that patients report back to their physician what they are experiencing. Don't feel like you're complaining. You need to let someone know how you're feeling and what symptoms you're experiencing so that they can be addressed.
Yeah, so we always like hearing from patients because that's, of course, why we're here. And she brings up some really great points. So key points, takeaways for us are, 1, there are significant disease burdens, as we all know, with these conditions. 2 is really discussing the chronic nature of the condition with patients so that we can set those expectations of possible recurrence and intermittent flares. And then also discussing sinus surgery, medical management. When do we expect things to start helping? How long do we expect them to help? Is there a chance that they may stop helping? All of those things are really important, as well as potential short and long-term side effects. So we'll move to our next section here, looking at the airway pathophysiology.
Oh, great. Thanks, Flavia. That was excellent. And that testimonial is pretty sobering. I mean, we all have patients like that, and sometimes, we do the best we can, but still the message doesn't get through, and I think we need more time with our patients too, and multiple visits. So going to some of the airway epithelium and the mechanistic aspects, it seems that a lot of at least from an ENT perspective, a lot of my patients come to me and they think that allergies or allergic rhinitis cause their polyposis. And I think a lot of physicians, perhaps ENTs, also have that concept in their mind, especially because we do have a disease called allergic fungal rhinosinusitis where there is a fungal, type 1 hypersensitivity that is contributing to the chronic inflammatory sinus problem. But so basically, if you look at this slide, the upper box is looking at some of the pathophysiologic mechanisms for allergic rhinitis. And as an ENT surgeon and a rhinologist, I won't go into teaching allergy to this audience. On the lower box, you see how there's this significant barrier disruption similar to what can happen in allergic rhinitis, but it is definitely much more complex. We don't quite understand it as well. Even the concept of fibrin mesh production and polyp formation and all of these things, it's still really not very well understood because we don't grow polyps necessarily in lungs. Maybe Mike will correct me. But in the upper airways, it's very interesting that patients who have inflammation, type 2 inflammation, even type 1 inflammation, we see polyposis. And you can see that you have innate lymphoid cells, eosinophils, neutrophils. I don't see mast cells there, but Dr. Layla, my allergy immunology partner, we would definitely be advocating for that here. But it's a cascade of events that is occurring with different insults that are potentially occurring. So I'm going to pass this along to Mike, who can talk a little bit about the asthma.
First of all, we don't grow polyps in the airways.
Okay, good.
I just said we have to teach the ENT doctors
Exactly.
a thing or two. By the way, it's fortunate that we've got different specialties here: an allergist, ENT doc, and I'm a pulmonologist. So, I mean, I know you're all going to focus on what the allergist says, but maybe Stella and I can teach a few things to you as well. So the asthma airway epithelium is so important to understand the lower airways, and what what's common between the lower airways and the upper airways. And we can see all of the different cells that are involved in the inflammatory processes, starting from the airway epithelium. This, on the left-hand side here, what we're showing you is a normal airway epithelium. And you can see there's a lot of cells that are just naturally there that play important roles in homeostasis of the airways. Now, in the asthmatic airway, all of those cells are oftentimes perturbed in a way. And usually it's a result of a variety of different stimuli. You get allergens, you get irritants, you get viruses, you get bacteria. Anything that can stimulate the airway epithelium can result in downstream production of a variety of different cytokines that can stimulate Th2 cells, ILC2 cells, to release their mediators, their cytokines, that can then work in terms of activating a variety of different cells. We can see the importance of the mast cell. We know that the mast cell releases histamines and other mediators. Eosinophils release eosinophil cation protein, major basic protein, eosinophil-derived neurotoxin, eosinophil peroxidase, amongst others. Those play important roles. And then there's important roles of fibroblasts and nerve cells in the airway as well. Now, there is this broad interactive cytokine network that is critical for the pathophysiology of asthma. After activation at the epithelial layer by all these different stimuli, the allergens, the viruses, and all the other irritants, the airway epithelium produces epithelial cytokines called alarmins. These epithelial cytokines include TSLP, IL-33, and IL-25. TSLP is important because it stimulates activation of ILC2 cells, innate lymphoid cells, as well as Th2 cells. And both of these cells, ILC2 cells, innate lymphoid cells, and Th2 cells, T helper cells, are important because they produce a variety of different cytokines, including interleukin-5. And interleukin-5 is critical for the maturation, proliferation, and activation of eosinophils that release their mediators. Now, these Th2 cells in particular also release interleukin-4, which plays an important role in terms of B-cell class switching that results in IgE production that can bind to mast cells and cause mast cells to degranulate in the presence of different aeroallergens. And also, a third cytokine that's produced is interleukin-13. And IL-13 plays a variety of roles. First of all, it plays a role in terms of mucus production. It secondly plays a role in terms of smooth muscle contractility and plays a role in airway hyperresponsiveness. And it also plays a role, along with IL-4, in terms of eosinophil trafficking to the tissue. There's also a role of IL-13 in terms of fibrin deposition and mast cell activation as well as smooth muscle activation that plays a role in asthma as well. And what you can see is, by looking at the different shaded colors, is that in many of these features are present in both asthma as well as chronic rhinosinusitis and nasal polyps. So you're getting a lot of the same effects going on in the upper airways and in the lower airways. And that's what we're talking about when we get to the unified airway hypothesis. Almost everything that happens in the lower airways happens in the upper airways as well. And so the key features of these interactive cytokine networks that play a role, again, both in the upper airways, and you can see the nasal polyps there, as well as the lower airways in asthma, is you get activation at the epithelial layer of different alarmins, including IL-33, IL-25, and TSLP. And then you get downstream production and activation of IL-4, IL-5, and IL-13 that are produced by the Th2 cells and the ILC2 cells. And this type 2 inflammation, we call it type 2 inflammation because these cytokines, IL-4, 5, and 13, are produced by Th2 cells and ILC2 cells. They play a critical role in driving not just the acute processes, but also the chronic processes that are involved in type 2 inflammation in both asthma as well as chronic rhinosinusitis and nasal polyps. Now, there's another important component that's non-type 2 related that isn't mediated by IL-4, 5, and 13. And there's a whole host of cytokines that get activated as well by some of the same stimuli, irritants, pollutants, microbes, including bacteria and viruses. And that can activate non-type 2 pathways with activation of Th17 cells and Th1 cells that'll produce their own cytokines, like IL-1 beta, IL-6, IL-8, IL-17, and as well as TNF-alpha. And these cytokines play a role in terms of activating neutrophils, but they can also play a role in possibly granulocytic asthma. Other components of the non-type 2 pathways include the role that IL-6 plays in mediating airway inflammation. And in the context of infection, oftentimes you'll get production of interleukin-6 and activation of neutrophils, and you get soluble IL-6 that gets released, can result in some of the other signaling that goes on, resulting in exacerbations. And oftentimes, some of these cytokines will play a role in terms of not just activating neutrophils, but also eosinophils can play a role, as well as macrophages, and that can all result in submucosal inflammation and airway remodeling. So that's the lower airway and a lot of what's going on in the upper airway. I'm going to pass the baton back to Stella, who's going to talk about what's going on in the upper airway in a more succinct way.
Great. So thanks, Mike. I'll briefly touch on this. I think we all know this for allergic rhinitis, just as a comparison to CRS with NP. We know that histamine is important, and eosinophils, basophils, et cetera, and the T2 effectors, as you can see here. And nowadays, even from the ENT side, we are moving away from phenotypes of seeing polyps or not polyps, but moving towards pathophysiologic mechanisms or endotypes. And so going to that question, I want to get a sense from all of you, which inflammatory pathways may be involved in the clinical manifestations of CRS with nasal polyps? Number 1 is type 1, 2 is type 2, 3 is type 3, 4, any of the above, or none of the above. I expect you to all be here. Yes, Doctor. Okay, great. So I believe 1, 2, 3. Any of the above, it was the most commonly chosen answer, and type 2 also was the second most. So let's go into that a little bit. So it's very interesting with CRS with nasal polyps. Initially, we all know about type 2 inflammation, but we realize that there is quite a heterogeneity and a mixture. And endotypes, that's where we're hoping to go towards for the future, really selecting patients based on their underlying inflammatory disease, and then being able to select the best treatment and also prognosticate. That would be great. So you can see here the different endotypes, T1, T2, T3, as you can see here. We typically think of T1 and T3 as more neutrophilic. You see more purulent drainage for these patients. You don't, and you don't really see as much smell loss, whereas in T2, you see more the polyposis, the loss of smell, but also the comorbidities are really important, as you can see on the bottom box. And it seems that patients who have, and this is why we're all here and why we want to get all three of us together and all of us on the same page, is that patients who have CRS with nasal polyps and or asthma and or allergic rhinitis, as well as AERD, they have the worst prognosis. They have more surgeries. They have the worst radiographic disease. They have the higher dependence on oral corticosteroids. And this is a great study done by Whitney Stevens. Just of note, this is done in the US. It is a bit different in other parts of the world, but you can see on the left pie chart all of CRS, in the middle CRS without nasal polyps, and then on the right CRS with nasal polyps. The red is T2. And as you can see here, the thought was, hey, if you have CRS without nasal polyps, it's probably more T1, or it's probably more T3. It's not probably T2. But this study kind of really showed us that a lot of CRS without nasal polyps actually are also still type T2. If you look on the bottom, you can see also the breakdown as well. T1, T2, T3. I think the most interesting part of this study was that if you look at the other parts of the pie chart, for example, the beige part, it's untypable. So there's still patients, we really don't even understand what their pathophysiologic mechanisms of inflammation are. And there are patients who are, you can see that black is all three, type T1, T2, T3 mixed, and a combination T2 and T3, or T1 and T3. So it is quite interesting to understand that there is a rainbow of different types, and every patient could be presenting with a different subtype or a mixture of types. So this is our next audience response question. Approximately how many of your patients with CRS have nasal polyps? So answer one, choice one is none, two is 25%, 50%, 75%, 100%, or I do not manage patients with CRS. Okay, so it looks like answer number two was the most popular, about 25%, and then 30% of you do not manage patients with CRS. So this is a great learning opportunity as well. All right. And you might have patients with CRS in your patient population. You don't even know. So, all right, going to nasal polyp formation. As I mentioned, it is still controversial. There's so many different research schools of thought about microbiome disturbances, about staph enterotoxin, about barrier dysfunction, similar to what we are seeing in the asthma world. As you can see here, one of the potential ways that polyps form, you can see here, there's the mucus layer, the barrier. Once the barrier is breached, you have the microbes that are, there's decreased diversity. And then you can see the recruitment expansion of inflammatory cells, the edema, the mucus production, the fibrin cross-linking that can lead to the polyp formation. Then you also have tissue remodeling, increase of mucus, but loss of submucosal glands in the polyps, and significant inflammatory cells that become a self-perpetuating vicious cycle. This is a patient of mine who has severe nasal polyps. It's interesting, a lot of folks sometimes confuse a turbinate for a polyp. Just wanted to point out, I don't have a pointer here, but the polyps are the ones on the top, and the inferior, this is on the right side of the nose, so patient's right, and the inferior turbinate is that tissue that's squished down by the polyps. And as you can see, this type of patient would have a very hard time breathing and smelling and leading a normal life. So I'm going to switch this back to Mike to talk about the effects of inflammation in the unified airway.
I wish we had a question to see how often you folks all look inside the nose. It's really important, and I think it's, obviously the ENT docs are going to do it all the time, and a lot of the pulmonologists that I interact with rarely look inside the nose, or they've told me that. They've told me that, and I say that a pulmonologist wouldn't know a nasal polyp if it hit him in the nose. So something to think about. So it's really important. Maybe, yeah. So I think it's really critical to take a look in there, particularly because we now have newer therapeutic options for our patients. So getting back to the unified airway model, and we recognize that inflammation is prevalent both in the upper airways and the lower airways. The consequences of that inflammation is the production of mucus and also the occurrence of airway hyperresponsiveness that goes on both in the upper airways and the lower airways. And some of that is a consequence or results in vasodilation and edema, and that can result in some of the sinonasal inflammation. Inflammation also can cause some smooth muscle contractility in the lower airways that can lead to airway hyperresponsiveness. So it's important to recognize all of these different features that can occur in both the upper and lower airway. We'll talk a little bit about mucus hypersecretion. We'll start off by looking at it in the context of chronic rhinosinusitis.
Yes, so I'll touch on this briefly because I think from the asthma world, there's a lot more that we could garner from that. But from this one slide, you can see that MUC5AC is one of the specific genes with overexpression through several signaling pathways. As ENT physicians, we deal with all types of mucus, and we know that mucus is a huge problem for patients. In general, though, however, smell loss and nasal blockage are the highest on the list for what bothers patients the most. But if you look at postnasal drainage and mucus production, that is on the top of the list as well. I won't go into all of the pathophysiology of mucus. There are many types of mucins and different overexpression of these MUC genes. But we do know that patients with mucus hypersecretion do have increased lower airway issues with poorer asthma control, more exacerbations, more frequent smell loss than patients without mucus hypersecretion. But I would say in general, most patients with CRS do have problems similarly to the lower airways with thick mucus and problems with mucociliary clearance.
So similar things happen in the lower airways where we also have mucus hypersecretion. And again, it results from a proliferation of MUC5AC expressing mucus cells. And there's the consequence of excessive mucus production can be excessive mucus plugging. And mucus plugging occurs particularly in patients with severe asthma. The mucus blocks up the airway and can have a significant impact in terms of how patients breathe, getting air in and out. Oftentimes, we think that a lot of this is eosinophil driven, it's IL-5 driven, and it's IL-13 driven. All of these cytokines play critical roles in terms of activating the cells that are involved in the mucus production and in MUC5AC proliferation and activation as well. So both IL-5 and IL-13 are critical drivers of the mucus production driven by MUC5AC amongst other different compounds. This can result in mucus plugging. The other key feature in asthma is airway hyperresponsiveness, which really reflects twitchiness of the airways. It results in patients coughing when then there's an interaction with some kind of foreign stimulus. And airway smooth muscles contribute directly to the airway hyperresponsiveness and contribute to the narrowing of the airways, contribute to the inflammation, potentially the remodeling that goes on through activity that it may include activation of fibroblasts. So the airway smooth muscle, we're starting to recognize plays an important role, not just in terms of contractility, but also there's a pro-inflammatory effects that can be associated with mast cell activity, release of mast cell mediators like histamines and leukotrienes and other chemokines, but also the airway smooth muscle can also drive mucus hypersecretion that occurs. And so we see this in asthma, but we also see it in chronic rhinosinusitis as well, which is also associated and linked to some of the airway hyperresponsiveness that occurs in patients with asthma. So this brings us back to the unified airway model. And the concept, again, is that there are key pathophysiologic processes that occur in patients with allergic rhinitis, chronic rhinosinusitis nasal polyps, and severe asthma that are associated with epithelial inflammation that drive both the type 2 as well as the non-type 2 inflammation, but can also drive airway hyperresponsiveness as well as the abnormal mucus production. All of these result in the manifestations of these different diseases that can occur in different ways depending on the target organs that are involved. So in allergic rhinitis, the type 2 inflammatory processes can result in itching and sneezing. In patients with chronic rhinosinusitis nasal polyps, there can be hyposmia or anosmia, facial pressure, and pain, all of which results from this type 2 inflammation, can result sometimes in sleep disturbance and fatigue. And then in asthma, you get the usual asthma symptoms resulting from type 2 inflammation, shortness of breath, chest tightness, cough, wheezing, and all of this can be involved. So we're now going to talk a little bit about how we can address some of these perturbations in both the upper airways and lower airways with novel therapeutic interventions?
So for the otolaryngologists, it's been incredible because we never had these kinds of options available to us for treatment of CRS with nasal polyps. And as you can see here, there are 6 FDA-approved biologics for asthma. I won't go through each one, but I think the key point is that they target different, for example, IgE, IL-5, IL-5 receptor alpha, IL-4 receptor alpha, and TSLP. And you can see the indications there. Currently, there are 3 FDA-approved biologics for asthma as well as CRS with nasal polyps. And you can see the indications there as well. So omalizumab, mepolizumab, dupilumab are the 3 currently approved for CRS with NP, and then also for asthma too. So briefly touching on the mechanisms, we know that omalizumab binds free IgE. We know what IgE does. It binds with high affinity mast cells and basophils. Mepolizumab blocks free IL-5, and Mike eloquently described what IL-5 does. And then anti-IL-4 receptor alpha, we know that IL-4 and IL-13 also have significant pleiotropic effects, including goblet cell development, B cell class switching, T cell differentiation, among other things. All right, going back to Flavia.
So just thinking about how far we've come, right? We've got these biologic options, but then there's still a lot to be done, right? So ongoing disease burden and unmet needs. Starting with allergies, we don't have any FDA-approved biologics to treat allergic rhinitis. So we'll talk about one study that's underway, but really that's a limitation. And most of our patients do okay, but our very severe patients really do have a lot of fatigue and mood changes, impaired cognitive function, depression, anxiety. So it doesn't cause mortality, but again, a lot of effect on quality of life and morbidity, as you all know. In terms of CRS, the main limitation here, again, now we've got 3 biologics, but they're all really targeting that type 2 inflammation. And so there are none that are approved for non-type 2 inflammation. And then in terms of which patients do worse, we've mentioned the patients with nasal polyps tend to do worse, the patients with comorbid asthma as well, and we mentioned some of the impacts clinically. So anosmia and fatigue, again, anxiety and depression can be higher in these patients. And then with regard to asthma, we do have tezepelumab that has no specific phenotype indication, but we don't have any specific biologics targeting non-type 2 inflammation. And even though we have all these different options, we still have a subset of patients that don't respond and where they need more help. And so, whether it's a different type of inflammation or it's more about the airway hyperresponsiveness, the mucus plugging, whatever it is, there's still a subset of patients where we really need to focus in. And these patients are the ones that account for the majority of our medical costs, our ER visits, and unfortunately, those are the ones who are at increased risk of death as well. I'll pass it back to you.
Oh, okay. And there are some ongoing phase 3 clinical trials for CRS with nasal polyps. Benralizumab, Ostro was the phase 3 trial that was completed. It didn't meet some of the primary endpoints and so was not approved. But they did start another trial called ORCID, and they're targeting a more specific group of patients. And so we need to review the results from that ORCID trial. Hopefully it should be coming out soon. And tezepelumab is currently doing a trial called Waypoint. We are one of the sites in Boston currently doing this trial. So we're very excited. We hope that this might be another option for us, for our patients with severe nasal polyps. So it's a wave of hopefully more targeted therapeutics, and more options, I think, are better. And as Flavia mentioned, with tezepelumab here, it's an upstream. It's targeting upstream protein, and we know that it's targeting TSLP. And you can see the downstream effects from allergic inflammation or eosinophilic inflammation or neutrophilic inflammation. And so hopefully we'll see the results of what it actually does for our patients with CRS with nasal polyps. Benralizumab blocks IL-5 receptor alpha, and we know that it's effective in our asthma patients, but it's interesting, it has always been a question of mine of why the upper and lower airways also respond so differently to different therapeutics. And you would think that a particular biologic may function similarly, but we do need to understand better of the differences of the upper and lower airways and the responses that occur when you block certain cytokines in the receptors.
And then, as I mentioned, not much being done in terms of looking at biologics specifically in allergic rhinitis, but we know that omalizumab has been shown to help patients who are building up with immunotherapy, and if they're having reactions and not able to get to maintenance, then omalizumab as an adjunct therapy can be helpful there. And then tezepelumab, interestingly, is just starting a phase 2 trial called TASARS, and it's actually looking at patients with comorbid allergic rhinitis and asthma. It's going to involve nasal challenge to perennial and seasonal allergens that will be done at baseline, at 6 months, and at 12 months. And patients will be receiving tezepelumab every month during that time. And so it's going to be interesting looking at different endpoints, peak inspiratory flow, and 2 different scoring systems for symptom scores of allergic rhinitis. But then also looking at biomarkers, so thinking about different cytokines in the nasal secretions, and then looking at TSLP expression in the genes, as well as some of the mast cell mediators. So more to come on that, but I think that'll be an interesting study to follow. And then just taking us back to our case, Amanda did mention that she's been on multiple biologics without complete relief of her asthma and CRS with nasal polyp symptoms. And so Stella's going to take us through kind of which patients should be getting biologic therapy and when should it be started, in particular in the setting of CRS.
So that's still a very controversial question, especially amongst our otolaryngology colleagues. I think the fields of allergy, immunology, and pulmonary, there's been more experience prescribing biologic therapies and also seeing what patient outcomes have been, as well as adverse events. But so the EPOS euphoria criteria were developed. We looked at different criteria. It makes sense. So the biggest issue is that for CRS with nasal polyposis, for our field of otolaryngology, we don't have a biomarker for this condition, unlike in asthma. So we have different criteria that we can see on the left-hand side of the screen. They all make sense. Patients should have evidence of type 2 inflammation. They should perhaps have tried an OCS and perhaps benefited and responded to an OCS, which would make sense. The patient should have significantly impaired quality of life, significant loss of smell, diagnosis of comorbid asthma. We'll go over all of these in a little bit more detail. The cutoff points are a bit arbitrary. I would say the evidence is still not strong, but these are very basic guidance on what we can use. We know that some, for example, papers and studies show that tissue eosinophils perhaps greater than 50 are probably much more realistic as showing polyp recurrence and type 2 inflammation. So these cutoff points are meant to serve as a guide, but they are not set in stone. The problem with surgery, and as a surgeon, polyps are, actually really fun to remove. Sinus surgery is a very satisfying procedure because patients immediately can breathe after, and they're so happy. But the problem is that the polyps come back. In some patients, I would say they do quite well if they do their saline irrigations, if they do their topical steroid sprays. But in some patients, the polyps do come back. And as you can see here on this diagram, on this table, you can see edema and polyp are in yellow and red, and blue is total. So even at 18 months, you can see that you do have some recurrence of polyposis and edema in about 40% of patients within 18 months. So going back to our patient, I wanted to just show you a video of my patient who has CRS with NP, and this is what an example of a nasal endoscopy looks like. This is looking on the left side of my patient's nose. You can see the inferior turbinate is squished off to the side. Those are the polyps that look quite fibrous, actually, which is a sign to me that they've been there for a while. There's some thick mucin and perhaps metaplasia of the polyp tissue because of the patient trying to breathe through their nose. So wanted to know from all of you, in your clinical experience, what percentage of your patients with CRS with NP have recurrence of nasal polyps after sinus surgery? Answer choice 1 is none, 2 is 25%, 50%, 75%, 100%, or I do not manage patients with CRS with NP. Great, so it's a mix. So most of you do not manage the patients with CRS with NP. I guess you refer them to us to manage those patients. The question was, what percentage of your patients with CRS with NP have recurrence of nasal polyps? And so most of you do not manage those patients. It looks like 40%, but the second most common was about half, 50%. So I would say that is on par. And then the next most common answer choice was 25%. So I think all of us have seen some recurrence of nasal polyps. Only 7% said none, which is very impressive.
What's it like?
So I see a lot of patients who have had recurrence of polyposis and need revision surgery. They've had 3, 4, 5, 6 sinus surgeries. And so in my practice, it's much higher, but I would say every surgeon says that their choice, they probably say that none of my patients who've had my surgery have had recurrence of their polyps because they've had the good surgery. And I'll talk about that in a little bit. But I would say realistically, it is about 25% to 50%. And it depends on the patient. If the patient has ARD, comorbid asthma, definitely. Those are the patients who recur.
And is there a better kind of surgery than a lesser kind of surgery that you can do?
That's a great question. So there is, I don't know how much gory details you want to hear after you're finishing your nice dinner, but so as surgeons, when we see patients who have ARD, who have CRS with NP with comorbid asthma, we think about something called a draft 3 procedure where we actually drill out the frontal sinuses and connect the left to the right. So we have a huge cavity. The frontal sinuses are where patients fail quite commonly, and there are some good papers that go over the evidence of doing a draft 3 does help decrease recurrence. And those papers were published a while ago, say the patients with ARD and comorbid asthma probably should have a draft 3, really, because they're the ones who are going to recur. But now that we have better options, maybe we don't have to drill people's sinuses as much. Any thoughts or questions about that?
No.
Yeah. All right. So as I mentioned, the patients who have comorbidities, especially as we talked about the asthma, the ARD, have the higher recurrence. Staph superantigen, this is something that's not prime time. We don't have a way to really measure this readily in the office. We briefly touched on that if patients have tissue eosinophilia, the counts per high power field may be a good indicator, prognosticator of someone who might recur. The higher the number, the higher the chance. Patients who have, so this is really interesting, neutrophilic infiltrate. So these are patients who might have a mix. So they might not be just purely type 2. They might have a type 1 or type 3 process as well. And so those patients have higher recurrence. And adherence is always an issue. These patients, and we heard the case, our patient testimonial about how the surgeon told her, you'll do your surgery and you'll be fine. But I try to be very transparent with my patients that this is not like an appendix that we take out and then we don't see you anymore. We will grow old together because until we have a cure for this condition, this is something that we have to continue to manage together. It's like asthma. It's something that is chronic and will have flares and remissions and exacerbations. And obviously, well, maybe not obviously, but the primary surgery, the studies have shown that the first surgery is the best surgery, and patients have better outcomes after that. When patients require more and more surgery, and maybe this is a selection bias, their outcomes, the gain on the return on investment is much less. And so let's talk a little bit about how many surgeries is too many. We're going to talk a little about, as I mentioned, the adequate initial surgery. So when we talk about adequate initial surgery, the interesting thing is when someone does a sinus surgery, it's not like a rhinoplasty. You can't see the result of what a surgeon has done because it's all internal. And the sinuses, I would say, are very forgiving. I've seen patients who've had very minor surgery, and it's been called a total FES, and some patients who've had a draft 3. So there's a very wide spectrum of what can be done with sinus surgery. And so when you talk to academic rhinologists, we debate a lot about what is that adequate initial surgery. Is it a draft 3? Should you be drilling out the sinuses, or should we do a complete ethmoidectomy where all the partitions are gone? You can see the skull base and the orbit, because oftentimes we don't see that. Most rhinologists or ENTs are not comfortable doing draft 3s, so it is quite a challenge. And so if that's the case, then that's why we see a lot of revision surgery. Patients have symptoms again, they can't breathe, they can't smell, they come to us, they want to be able to live a normal life. And so they want to have surgery and they want to have that immediate result. They don't want to do steroids anymore. So revision surgery can be an option, but it's very important to discuss the goals, and definitely that this is not a cure. We do not have a cure for this condition, not even the biologics are not a cure. And so we know that the pros and cons of each need to be discussed, and that's what informed consent is, discussing what every potential option is and what the pros of each different option are and what the adverse events of each or effects of potential treatments are. And then if we deem the patient has had adequate surgery, then perhaps a biologic therapy can be an option, especially if they have a comorbidity such as asthma. We do at Brigham and Women's Hospital, we have a multidisciplinary case conference. And I think it's also important, and this is why all three of us are here too, is that I don't think any one person, especially for a patient who has CRSwNP with comorbid asthma and or allergic rhinitis, and they often commonly occur together, it's important not to take that burden onto yourself to say, hey, how do I choose which biologic? It really is helpful to discuss with your colleagues and to make the decision based on what in that multidisciplinary discussion unfolds. So, and then factors orienting towards surgery, and then factors orienting towards biologics. So this can be, we'll discuss this in a little bit more detail. I think the discussion at the end, towards the end might be more interesting instead of me lecturing about what might be best. But really it is patient shared decision making. That really goes down to it. Sinusitis, and Flavia mentioned asthma, patients die from asthma. Patients do not die from CRS with nasal polyposis. So this is a quality of life condition. If patients don't want, for example, last week I saw a patient, I would say it was stage 5 polyps. Stage 5 doesn't exist, but basically a mustache of polyps growing out of both sides of his nose. And I've seen that several times. And one patient actually said, I don't want anything done. I don't want surgery. I don't want a biologic. I don't want anything. And that's fine. So it's patient shared decision-making, patient preferences. If they do not want to have surgery or they don't want to inject themselves, they don't want to rinse, there's a big discussion. So the question that I'm going to start the discussion between the three of us is there a role for combination? Do any of you do, so Flavia, do you ever do a combination of biologics and work with your ENT colleagues to do surgery as well? Or do you try one and then try, like this patient, Amanda, tried 3, I believe, biologics?
And 3 surgeries, right?
Surgery, right, okay.
Yeah.
And then, so what is your algorithm and how do you decide where to start and where to go?
Yeah, so I usually will get ENT involved right away. And hear what they have to say. So it depends on if it's the very first time they're going to have surgery or if they've had multiple surgeries. We're very fortunate we have a rhinology team, and I do think that makes a difference to have a rhinologist versus a general ENT. And so if somebody said, well, I saw my ENT and they said blah, I usually say, why don't you see one of our rhinologists? And they see sinuses all day, every day, and before you do a surgery, I want them to kind of weigh in. So I will get them involved right away, and then we usually have, again, shared decision making with the patient, but then also that multidisciplinary approach. Generally, like it's either me sending it to ENT or ENT sending to me to get the biologic on, particularly in those more severe patients where we feel like the polyps are definitely going to recur and they're already having worse outcomes. Just right away getting them on a biologic so that either they have the surgery and then they're on the biologic to keep them away from recurrence, hopefully, in addition to the topical therapies. Or maybe, and we talked about this ahead of time, that sometimes there's so much inflammation that maybe getting them on the biologic before surgery would actually increase the success of the surgery. So I feel like it goes both ways, and really it's very patient dependent. So every case is different, and just like you said, having that multidisciplinary discussion every time.
So are there head-to-head data comparing biologics to surgery? And my second question is the point that Flavio brought up, which was, does it make a difference with regard to having a ENT specialist in general versus a rhinologist who's going to evaluate?
So the first question, there isn't a randomized trial of surgery versus biologic, and I wonder if that's the right question too. No,
it is a good question.
No, it's a good
Versus
question,
both.
but
What would be your question?
Yes, yes. So we actually did the study when I was at University of Pittsburgh, and we were one of the first sites, to do some of the trials for dupilumab, for example. And we case matched patients who had undergone sinus surgery with their NPS scores, SNOTs, and all that stuff, with patients who had undergone dupilumab. So we compared the FES group to the dupilumab group, and what we found, and there were about 50 patients in each group, and what we found was that the surgery group was significantly better for their nasal polyp score. They did better than the dupilumab group, and this was over about a year time. But for smell and for drainage, like postnasal drainage and mucus, the dupilumab group did better. But this, of course, this is a small institutional study that we did. I just reviewed several other papers that, they're looking at different meta-analyses, so that's still being done. But I'm not aware of any head-to-head studies on surgery versus biologic. I think the interesting question that I want to ask you too is, what do you think about combining or strategies of instead of using this is maybe really expensive, but instead of, for example, we had a patient who was a pediatrician, had severe polyps, had surgery before, came to me, did not want to have more surgery, and I said, this biologic would be great. But then we did the CT scan, and it shows that he has a huge osteoma that was 2 millimeters maybe 5 years ago, now has grown. So obviously he needs surgery. But I was thinking, gosh, wouldn't it be wonderful if he could go on a biologic first, then have the surgery, because it was right next to the brain and the eye, and I'm working with a neurosurgeon, and then maybe continue the biologic or consider stopping it after. So. Yeah, what are your thoughts on combination treatment?
I think that it's a very reasonable approach. So the question that I would ask is, would be, I would try to design a study which would take the approach of either a biologic or surgery or a combination of the two, and then see what percentage of patients fail each of those and need to be crossed over to the other one at that point. But there's a strong rationale, I would think, about using a biologic first to sort of debulk the inflammatory processes and then maybe whack out the polyps. And I use that term because that's how I sort of envision you surgeons doing it. But I think there's a strong rationale for doing that kind of strategy. But I think we need to gather more data, and it probably needs to be done in the context of some randomized clinical trials.
Yes, yes.
And obviously shared decision making is going to be critical for all of this as well, because some patients are going to just say, yeah, just take them out, and if there's a problem, I'll go on to a biologic. Some people are like, I don't want to undergo surgery under any circumstance. And so you have to balance all of those patient preferences.
Oh, one other thing is that patients that I've seen who are want to have a family, I was curious what both of you thought too. A lot of those patients are thinking about biologic, but then if they are thinking about having kids soon, they usually choose surgery because that's there's not much data on biologics and pregnancy. Any thoughts on that?
Yeah, I mean, Xolair recently published the Expect trial, and so that's over, they've been out for 20 years now. So a lot of data there and showed that patients who were pregnant that were in this registry and receiving Xolair did not have an increased risk compared to population norm in terms of, birth defects, anything like that. So we think they're safe, but I think if I were recommending one over the other in that particular case, I would probably reach for omalizumab just because we have that one study with a lot of good data.
I agree. I think you have to, again, balance and take into account patient preferences and go through the potential risks, potential benefits, recognizing that a lot of data are not available in the context of pregnancy. So, I think there have been a lot of recommendations about patient selection for biologic therapy, some from the EPOS Euphoria group, which really recommend specific cut points and recommendations for when should a patient be put on a biologic. And so someone who has had sinus surgery, has had FES, and has evidence of type 2 inflammation, as demonstrated by having either eosinophils or elevated IG or tissue eosinophils, all those would be potential indicators of type 2 inflammation that might warrant a trial with a biologic therapy. In asthma, we think about eosinophils, exhaled nitric oxide, and IgE as the three key biomarkers, with both eosinophils and nitric oxide being predictive biomarkers that will predict response to biologic therapies such as anti-IL-4, anti-IL-5, and anti-TSLP. IgE is not a great predictive biomarker, but it does give you a sense of the inflammatory milieu, and it also isn't necessarily a great response biomarker to anti-IgE, but it does go down with dupilumab as well as with tezepelumab. So these are the biomarkers that we utilize in the context of asthma, but it can be helpful in terms of identifying what are the pathways of inflammation that are going on in a sinus patient and or in an asthma patient that may dictate which strategy we're going to utilize. So the biomarkers that we have, they can be useful as diagnostic biomarkers. They can say, okay, well, this person's got a high IgE. They likely have an allergic component, a mast cell mediated component. They can also be prognostic biomarkers. They can tell us, well, if you've got high eosinophils or high nitric oxide, you're likely to have lower lung function. And they can also inform you in terms of how predictable the biomarker is in terms of responsiveness to a different biologic therapy. We know that patients who've got higher nitric oxide and higher eosinophils tend to have more exacerbations, but they also tend to respond best. They tend to be the best responders to the biologic therapies we have. And for eosinophils, usually it's very predictive of responsiveness to the frankly, all the different biologics. Nitric oxide elevation is a predictor of a good response to dupilumab as well as to tezepelumab. So when we think about these patients, we think about the biomarkers, but we also think about clinical criteria. So how often is a patient requiring oral corticosteroids? Or does the patient have a contraindication to oral corticosteroids? They have diabetes or something else that would preclude that. How significant is their quality of life being impaired? And how significant is the loss of smell? So we utilize a few different tools to evaluate these things. We generally want to see a patient have at least 2 exacerbations requiring oral corticosteroids or being on chronic oral corticosteroids. Those are the most severe patients. But the general feeling about oral corticosteroids is that in 2024, we should really have almost no one on chronic oral corticosteroids. We should be trying to get those patients off oral corticosteroids and on other therapies. We also can evaluate utilizing different scales the degree of impairment of quality of life in terms of their sinus disease, the SNOT-22 score. I think it was developed in Pittsburgh. And then there are other patient-reported outcomes. We have to recognize oral corticosteroids for what they are, which in most people feel is now treating me with oral corticosteroids is considered a treatment failure, actually. And that's because of all the side effects associated with oral corticosteroids, whether it's cataracts and glaucoma, whether it's osteoporosis and hip fractures, whether it's weight gain, whether it's mood disturbances, whether it's muscle loss, whether it's increased risk of DVT and stroke and cardiovascular manifestations, or whether it's the increased risk of diabetes and infections that can occur. All of these things, as well as adrenal insufficiency, are major side effects of chronic oral corticosteroid use. And even cumulative courses, even if patients aren't on corticosteroids over the long term, cumulative use of oral corticosteroids over years are associated with increased risk. If you have 2, 3, or 4 courses in your lifetime, you're at increased risk of all of these different side effects. And we say that patients who are on 7 to 15 milligrams a day are associated with the largest increase of some of these adverse effects, including fractures, and a few courses can result in significant toxicity. So Amanda has said that she has already been developing cataracts. You heard her say that she was turning 50 the next day and she is getting cataracts. And it was presumed that this is due to her oral corticosteroid use. However, when she began use of the oral corticosteroids, she felt that the benefits outweighed the risks. So an important question is how do we get patients to recognize, and I get patients calling me all the time saying, I need some more steroids. And so we have to think about what are some of the options. So I'll pose the question to you guys. What are the therapeutic options that can be used to reduce oral corticosteroids? And let's hear what the audience has to say. We can talk first amongst ourselves or either way. But what are some of the therapeutic options that can be used to reduce oral steroids in patients with asthma, allergic rhinitis, or chronic rhinosinusitis? We've talked about pretty much all of them already. We've got 3 that are approved in chronic rhinosinusitis nasal polyps: omalizumab, mepolizumab, and dupilumab. And in asthma, we have those 3, plus we also have reslizumab, which targets IL-5, benralizumab, which is being studied again in chronic rhinosinusitis nasal polyps, and then tezepelumab, which is the most recently approved. And there are other therapies that are on the horizon. They're long-acting ones as well. Let's ask the audience what their thoughts are. What percentage of your patients with chronic rhinosinusitis nasal polyps and asthma prefer to continue long-term oral corticosteroids as opposed to starting a biologic therapy? 1 is none, 25%, 50%, 75%, 100%, or last answer is I don't manage patients with comorbid chronic rhinosinusitis nasal polyps and asthma. Take a few seconds to answer. All right, let's see what the answers are. So none, that's similar to what I would say. None of my patients prefer to be on long-term oral steroids opposed to starting biologic therapy. There are some people who don't manage these patients. But as you can see, as most of you felt, most of your patients would pretty much rather not be on oral corticosteroids. My patients hate being on oral corticosteroids. What are some of the comments you get from some of your patients about chronic or as well as short-term oral corticosteroid use?
I think it's a lot of love-hate. So I think they'll say, oh, if I really need it, I'll take it, but lowest dose possible, shortest course possible, because they know it works. But to your point, they know, and they're usually talking more about the short term, like how they feel. They're eating too much, they can't sleep, they're anxious, they can clean the whole house overnight, but then they're miserable. So that's usually what I hear from the patient. I think once we've had the discussion about the long-term risks, then they start kind of factoring that into their discussion. So patients who have been diagnosed with cataracts or diagnosed with osteoporosis, then they start talking about, well, I don't want any more because it's going to increase my risk even further. But I usually have that discussion very early on, just so that they have a healthy respect for the steroids. Like you said, we love them, we hate them, but.
Yeah, but I've got patients who have a stash of steroids. They don't even tell us oftentimes.
Right.
They've been hoarding steroids for years, and they'll bring in their bottle, which is from like 2008, with like their 100 prednisone tablets that they got back then. So I think it's important to think about when choosing the biologics, it's important to think about comorbid asthma and regular need for inhaled corticosteroids. The other thing that we need to think about is what are some of the other things that are going on with regard to their diseases. And patients who've got a lot of mucus plugging that can be associated with increased airflow obstruction, worse lung function, more frequent asthma exacerbations, those would be people that you might also want to think about using a biologic for, because that can have a significant impact. The more mucus plugging people have, the more frequently they're going to be having asthma exacerbations, the more frequently they're going to need more asthma medications, and that also puts them at increased risk of respiratory tract infections. So mucus plugging is another important thing, and we can evaluate mucus plugging. We can do it bronchoscopically. We do that at National Jewish and with our pulmonologists, but we can also look at it now radiologically, and we're getting better and better at looking at imaging tools. And there are CT scan mucus plug scores that can evaluate the number of lung segments that have observed mucus plugging. And patients who've got more than 4 of those segments tend to have increased morbidity associated with worsening asthma. So for those patients, we really need to think about, considering other therapies, including biologics, to address some of these symptoms. And does the presence of mucus plugging affect, as a pulmonologist, I can tell you that it affects my patient practice, but what about you guys? Does it affect either from an ENT perspective, when you might consider a biologic, or Flavia, in the patients you see?
Yeah, to your point, the outcomes you just mentioned certainly push me more towards a biologic. I know there's inflammation driving that mucus plugging, and so getting started earlier and then kind of thinking about which biologic might do the best job at targeting those mucus plugs.
So something else to think about in considering utilizing the biologics. So back to Amanda. She mentioned that one of the biologics that she took helped with her asthma, but not with her chronic rhinosinusitis or nasal polyps. So I think it's really important to evaluate these things, because sometimes patients will say, yeah, my asthma is a whole lot better, but my sinuses got worse, or vice versa. They'll say, yeah, my sinuses got better, but my asthma still isn't good. And I've gone back and forth. So we have to ask ourselves, how do we weigh the decision to switch biologics when one of the entities is well controlled and the other isn't? And that's a real challenge. And I think to help answer that, we need to start looking at biomarkers and talk to the patients, and hopefully we can also identify therapies that address both the upper and the lower airways. So we're going to talk a little bit about that, and we'll talk about the new concept of remission and disease modification as part of our management of patients with these chronic inflammatory airway diseases.
So in a few slides to go over some of the more recent publications that just came out. Actually, this year, we actually did not have these kinds of definitions in our field until just now. And so these are some newer concepts for us, including concepts of disease control, on treatment, remission, no symptoms or no endoscopic signs of active disease, plus no symptoms for greater or equal to about a year, and for cure, which we're always I think all of us are hopefully really trying to attain, hopefully in our patients, for greater than 5 years.
And ideally, that would be off of treatment as well.
Right, off treatment.
So there we're really having an effect in terms of disease modification.
Yes, and disease modification and remodeling, all of those concepts are quite new for us, and so we are really trying to define those in more detail. These are, I think, the key takeaway point from this. I don't think you need to really look at the nitty-gritty, but the key takeaway point there are some criteria that we decided upon. This was expert opinion, really, and there are some data to support it, but we thought, what is a MCID, or what is the minimal clinically important difference for the criteria we should look at for a nasal polyp size of decrease of 1? Is that enough to say that patient is getting better? But as you can see here, the reduced need for oral steroids, surgery, improved quality of life, smell, reduced comorbid conditions as far as defined by MCIDs for other T2 disorders. And then the other takeaway point I wanted to highlight is that these patients require continual follow-up. I would say 6 months is a long time to wait. For my patients who I start on a biologic in combination with my pulmonary and allergy immunology colleagues, I see them back within about a month or two of starting treatment, and then depending on how they're doing, even monthly, or if they're doing great, then we can extend out that time. And then you have to reevaluate the patient, whether they're happy with it, whether there's a really interesting study that was just published actually this year as well by Whiskey-Fokins, looking at whether you can extend the treatment time between biologic therapies. They went all the way up to 12 months in about 17% of patients. So it was interesting, but most of the patients, they were able to increase the time between doses. So they did an interesting real world study on whether you can extend the time between treatments. But that still really is controversial, needs to be further studied. So as Mike mentioned, disease modification, we hope, and we maybe in the future, we will be able to alter the course of the disease process, the underlying mechanisms of inflammation, and attain that cure. But as of now, we really are trying to understand better if perhaps even if we can do a combination treatments of, we know that basal epithelial cells carry the memory of that inflammatory pathomechanism, that perhaps if you do sinus surgery and in combination with other treatments, that can help with disease modification. That really needs further study.
And so just talking a little bit about clinical remission in asthma, so also a relatively new concept. It's been talked about over the years, but really in 2020, the concept was kind of brought about in the literature with this modified Delphi survey approach. And so Menzies, Gow et al. Published the following criteria. So that same time frame as for CRS of 12 months. And what we're looking for is patients who have sustained absence of asthma symptoms. So using a validated instrument such as an ACT or ACQ. Also optimization and stabilization of lung function. So we're not saying normalization because again, patients who are very severe, you're never going to get their lung function normal. But if you can stabilize them at their optimum lung function, then that patient can still get into remission. And then interesting criteria number 3, patient and healthcare provider agreement regarding disease remission. So this is a conversation that has to be had with the patient who, with asthma has probably never heard the term remission. And might actually think of it as cure, because we think in cancer, oh, I'm in remission, right? And your mind automatically goes to cure, but this is not what we're talking about here. Generally, this is on therapy. And then no use of oral corticosteroid therapy, either for exacerbation treatment or for long-term disease control. And then more recently, last year, there was a publication looking at a consensus agreement. So, as Stella said, this is mostly expert opinion, but the college, the academy, and then ATS came together to publish kind of an updated guidance on clinical remission. And there's a lot being published here because a lot of this is still up in the air. So you'll see some similar things that just came up on the 2020 publication. So no exacerbations is on there again. Number 3, so stabilization and optimization of pulmonary function is on there. And then number 5 is looking at those validated measures. But there's some new things on there. So number 2, no missed work or school over a 12-month period due to asthma-related symptoms. So that's pretty stringent, hard to attain. Also number 4, so continued use of controller therapies, but only at a low to medium dose of ICS. So again, you're thinking about these severe patients who are starting biologics. Most of them are on high-dose therapy. And so the push is to kind of lower that ICS dose before you can really call it remission. And then lastly, number 6, the symptoms requiring one-time reliever therapy no more than once a month. So I don't know how many of your severe patients only use reliever therapy once a month or less, but I think that that's also a very, very high bar to reach. So again, this is just the latest one to come out. I'm sure that this is going to be kind of moved around over the next few years here, but the idea really is to treat to the target, to aim high, and if we can aim for clinical remission, then great. And we should be doing that. We should be phenotyping our patients early and really trying to do that. So this next slide here, this is a chart from a publication in Chest in 2023 that Mike was actually involved in. It's a great table looking at the different studies of biologics and their ability to help patients achieve clinical remission. So again, we're talking about our more severe patients here, right? Because they're severe enough to qualify for biologics. And many of the criteria are similar. So absence of symptoms was pretty much across the board with ACQ or ACT in all of these studies. And then no exacerbations and no OCS, that third row there, also across the board. Lung function was factored in most of these studies, but there are a couple that left lung function out. And you can see the bottom row there, prevalence of clinical remission. The rate is anywhere between 14% and 43%, depending on the drug, the study. Some of these are looking retrospectively at the phase 3 trials and then asking the clinical remission question. Some of them are looking prospectively and are more real world, like the Zalox study. And then there are some that are actually comparing multiple biologics. So definitely something to just kind of think about in practice, aiming for remission and phenotyping earlier than that kind of traditional step 5 where we're letting them get exacerbations and oral steroids and airway remodeling on the way to the phenotyping. We want to think about that earlier. And then this is just an interesting study about tezepelumab. So Destination was an extension trial of Navigator and Source, looking at patients after they stopped the tezepelumab and seeing what happened. And biomarkers and clinical status actually worsened off the tezepelumab, which you would expect, but they did not return to the pre-biologic level. So there was a level that actually remained. I'm not sure if we followed them beyond the 9 months, if we followed them several years, whether that would still look the same, but it's an interesting finding nonetheless that maybe there's some disease-modifying effect here, where traditionally we've thought of the biologics really as more disease-controlling rather than disease-modifying.
Okay, so some of the key takeaways, I think, from our discussion is that we know that the upper and lower airways are closely related, and some of these diseases frequently coexist together in the same patient. And these patients suffer quite a bit from these comorbidities. And when you have these coexisting conditions, they tend to be more difficult to treat, and the disease is more severe. Biologic therapies are now a new option, at least for us, and there are new ones coming out for the asthma world as well. And they've been demonstrated to be safe and efficacious and helpful in improving patient outcomes. And I like your point of saying that we should aim high. We need to think about remission, and we need to think about cure, because if we don't even have definitions or think about it, how can we even get there? So having this multidisciplinary discussion is great, and I think it's so critical to help improve the care of our patients. So I think we're just going to do post-test questions and have a discussion. So these are the similar questions that we did at the beginning. So we'll see from pre and post how all of you did. So post-test question 1, which of the following plays a key role in orchestrating the upstream activation, both T2 high and T2 low, non-T2 inflammatory disease pathways in upper and lower chronic inflammatory airway disease? 1, TSLP, interferon gamma, IL-17, or IgE? I encourage you to write down your questions for us, and happy to answer them as best as we can.
We've got some questions here.
Okay, great. Yes, 91% of you said TSLP, which is the right answer. Oh, and it's up from 70%, so we see before and after. Alrighty. Next post-test question is, based on the EPOS euphoria criteria, which of the following scenarios would indicate that a patient with CRSwNP who has bilateral polyp recurrence after surgery may benefit from implementation of a biologic? Pheno greater or equal to 20, SNOT 22, that's greater or equal to 30, comorbid asthma with occasional ICS use, or daily low-dose OCS use for the past 3 months? Great, so most of you said 41%, so presence of comorbid asthma with occasional ICS use, and then 30% of you said daily low dose And the answer is number 4, but as we mentioned, these are not criteria set in stone, and there's definitely still a lot of discussion about which scenario would indicate that that patient might be a best candidate for biologic therapy. So that conversation is ongoing after surgery. And after surgery, we don't whack out polyps either. It's a very meticulous procedure. All right, post-test question 3. Jane is a 35-year-old woman. I won't go through all of them, but this is a very similar question, or the same question from the beginning. Patient has CRS with nasal polyp symptoms. They're well controlled, but continues to struggle with severe asthma symptoms despite the low-dose OCS along with ICS/LABA/LAMA. What would you recommend for Jane at this time? Sinus surgery, CT of the chest to assess for mucus plugging, refer for bronchial thermoplasty, or increase in OCS dose? Great. So I don't know if Mike or Flavia wanted to comment on this question, because I'm definitely not the expert for mucus plugging. I think the majority of all of you
So
picked the right
her
answer.
chronic rhinosinusitis is well controlled, so there isn't a strong rationale to do another sinus surgery. And while bronchial thermoplasty has been shown to reduce exacerbations in patients not utilize that broadly, certainly increasing her oral corticosteroid dose, maybe in the short term until she can get a biologic therapy, might be an okay option. However, the side effects of oral steroids and the likely lack of incremental benefit of going up on her low-dose oral corticosteroids is pretty small. And so checking for mucus plugging, that would be another rationale to consider a biologic therapy that might reduce not only the mucus plugging, but also address some of her upper airway symptoms as we discussed.
Okay, so now how often, now it's in bold, will you now consider the presence of comorbid chronic inflammatory airway disease, including allergic rhinitis, CRSwNP, when choosing a biologic therapy for patients with severe asthma? Never, 25% of the time, 50, 75, 100% of the time, I do not manage these patients. Oh, yay.
Thank you.
Thank you. Yes. So 63% of you said 100% of the time, yes.
Yes.
All right, so now that's the end of our presentation, and we'll now go over some of the question and answer.
Yeah, you can feel free to write down questions, raise your hand, someone will come around and bring us the questions, or if you feel bold and you want to get up, we're happy to do that as well. Oh, you got a bunch already?
I have some to start. Let's see. So what do we know about allergy immunotherapy in CRS with nasal polyps? And you kind of started off by saying that everybody thinks that it's the allergies driving the polyps, but really it seems very distinct.
So they coexist, and patients who have, and we do ensure that these patients, especially if they have a clinical history of allergic rhinitis, do get testing. That immunotherapy can be helpful for management of those symptoms of sneezing, itchy eyes, pruritus, et cetera. But as far as modifying the CRS with nasal polyposis, even in patients with allergic fungal rhinosinusitis, it's still controversial. So it doesn't seem that, they are common parallel kind of disorders in the same patient, and they share common pathophysiologic mechanisms, but whether that can be disease modifying for the polyps, we don't think that has been shown. So it's a good idea to definitely help manage the symptoms, and it's a disease-modifying treatment, so definitely recommended, but not for specifically the polyposis.
Yep, and you see that with the AERD patient who had allergies growing up, and then they get the AERD, which is adult onset, right? And they're thinking, well, my allergies just got worse, and you're thinking, no, this is totally different. Yeah. So again, you want to treat the allergies, but really kind of shift the focus and educate and validate. So Mike, I know you and I have had this discussion in the workroom. Are there any potential utilities to combining biologics? So I know we share some patients that are on more than one.
So there might be, and it's an active area of investigation. We just looked, because I've got a fellow who's looking at this. We've got 24 patients, I think, in National Jewish who are on combination biologic therapies. And the rationale for it is there might be multiple pathways that are active in a given patient. And let's say they're getting anti-IgE therapy, but they continue to have eosinophilia. The anti-IgE therapy may not address that, but they might be doing well from a certain perspective. Then you could target the IL-5 component. Or if they've got different comorbidities, let's say someone has eosinophilic asthma and they respond well to anti-IL-5 therapy, but they've got high nitric oxide or they've got atopic dermatitis, that is a comorbidity that you might want to consider. They might be a good candidate to switch to add on dupilumab. Now, oftentimes you'll be asked about, you might consider these options, and the payers might say, well, don't add on, switch, try something different. Sometimes you can get it through. Now with drugs like tezepelumab, which works upstream, that to some extent addresses multiple pathways at once. And so I think there's been less use of combination biologics therapies, if you can get it through the payers, by just treating them with one agent that works more upstream. But sometimes you might need to do that. And I can tell you there are some drugs in development. There is a TSLP IL-13 nanobody, for instance, that might target different components of the pathway, and people are looking at all sorts of different combinations and permutations. We know that dupilumab, which targets both IL-4 and IL-13 by blocking the IL-4 receptor, sort of leverages that concept of blocking two different cytokines. So there is a potential role, but it's expensive as hell. So I would approach it with caution and make sure your patients know they could get a big bill if it's not covered.
And we also don't have the safety data. That's the other thing I've heard come up is kind of, we just don't know. I mean, we can assume they're safe because each one individually is safe, but we're not, there's no way of knowing for sure that the combination is safe. Okay, this one is about biofilms. So are there specific patients who develop biofilms and tend towards chronic inflammation? How much do you deal with biofilms as a...
Maybe we can start off by defining biofilms.
Good point, sorry.
Yeah, so biofilms are, I describe it to patients, they're like condominium complexes for bacteria, microbes, very resistant to our antimicrobial therapies. So oftentimes they're very difficult to remove, and also for patients, even after sinus surgery, you see these huge crusts of mucus and microbial colonies that are existing that are really difficult to eradicate. There's been a lot of debate of whether biofilms cause the underlying problem, but that's I think we realize it's much more complex than that. No amount of removing the biofilms is going to cure the patient of CRS. And so we think that likely it's the underlying host immune problems as well as the barrier issues. It is a vicious cycle that occur. With that said, we know that patients who have, now that we have a better understanding of different endotypes too, it seems that patients who have, like for example, good response to macrolides or doxycycline, we are using these medications for their anti-inflammatory effects, but they do help control some of these patients who have difficulty with chronic inflammatory but infectious flares. And over time, also with patients who have multiple sinus surgeries, what happens is, you can imagine, similar to what happens with bronchiectasis, you're having the same problem with the sinus mucus lining, that the mucociliary clearance is not so good. Then you have collection of, you have mucostasis, and then you have infection that occurs over and over. So it's a difficult problem, but I think it's really fascinating that now with the biologic therapies, we do see that when we do treat these patients with multiple strategies with biologics, the biofilm problem does get better. And we see that even with cystic fibrosis, with triple drug therapy, with Trikafta. I would never have imagined that the biofilms that we see, these are the patients with the worst severe biofilms, that they go away. So if you can maybe fix or not fix, but ameliorate the underlying inflammatory process, then the bacterial dysbiosis also gets better.
Yeah.
Any thoughts on that?
We're utilizing in asthma as well. We utilize azithromycin 3 times a week. There have been some good studies showing, Peter Gibson from Australia has shown in his study, there's also a more recent pediatric study that giving azithromycin 3 times a week and might play a role. And these date back to the 1990s when Monica Kraft and Richard Martin were doing studies with clarithromycin because they found that many patients were colonized with mycoplasma or chlamydia and whatnot. So it's potentially beneficial in the asthma world as well. So again, another commonality that brings the unified airway hypothesis together.
And this is for how long?
Usually
how
usually you give 6 to 12 months and reevaluate. But you, pardon me? Yeah, so it works well in both type 2 and non-type 2 patients. In fact, there was just a paper accepted looking at remission criteria from that study that showed that there's a significant number of patients who actually achieve similar remission rates as with the biologics using antibiotics.
By the way, with regard to microbial diversity, it would appear that antimicrobial peptides are going to be increased in T2 inflammation and decreased by an IL-13 type antibody. And so it would seem to me that a drug that would interfere with IL-13 would have its best effect on decreasing the biofilms. Wondering if there's any information that would suggest, I mean, that would be the theory. Do we have anything that suggests that that's the way it is? In other words, is there any...
I think something that if it's not being looked at should be looked at. But I agree with you that looking at the specific. Yeah. I mean, I think Yvonne Wang has done some work looking at the microbial diversity of the lower airways and airway microbiome and suggested significant diversity, certainly in the lower airways, but probably similarly in the upper airways in these patients.
Perfect. And then the next one is about aspirin exacerbated respiratory disease. So I can start off on this one. The question is, do you use aspirin desensitization or give biologics? And that is a great question. I think it depends very much on the patient. Certainly when I started at National Jewish, every patient with AARD got an aspirin desensitization, hands down. And now they're very rare because patients don't want to necessarily be on high dose aspirin, right? It's a lot, it's a big dose, 650 twice a day to start. And so if you can give them something that gives them almost immediate relief and similarly treats the upper and lower airway, a lot of them are heading towards the biologics. This has been looked at in the literature a little bit, and there's a nice meta-analysis that basically points that biologics win out across the board except for cost. And then of course for cost, aspirin is hands down the winner. So I do still use aspirin desensitization. It's mainly the patients who either are already on the biologic and aren't fully responsive, and we're still looking for another tool, so we'll add on the aspirin desensitization. I've had some patients who are needle phobic and don't want anything to do with the biologics, and so then aspirin's still a nice choice. And then I've had some who are actually cost conscious and say, well, let me try it. If it's not cutting it, then we can add on the biologic. And then of course the patient who needs the aspirin for another reason, then obviously the aspirin desensitization is still very relevant. So I don't know.
Use more after surgery? In other words, surgery first and then desensitization?
So that's how my practice has always been, to partner with ENT. They do the surgery, 2 weeks later we do the desens. But oftentimes now the biologic kind of creeps in and is either already started.
I think there's increased use of the biologics now that probably, we used to share a lot of patients in whom you were doing the aspirin sensitization, and I feel like we're doing a lot less of that now.
Yep.
And again, we're in a bit of a data-free zone. We don't have head-to-head results, study results looking at biologics versus aspirin desensitization in those patients.
Yeah. And we're doing less surgery too.
Yeah.
Because of the biologics, yeah.
Let's talk about the side effects of aspirin desensitization. Giving a very high maintenance dose of aspirin on a regular basis, you wind up with a hole in your gut.
Yes.
Or ringing in your ears, yeah.
Yeah.
And it's interesting, the side effects are always cited as much less than what I would expect. I'd expect everybody to have a hole in their gut, and it's usually like 5% for the GI side effects, 5% for the urticaria. But 5% is not negligible. So I agree, if the biologic is for most patients free of adverse events, then it's hard to push.
I'd like to make a pitch. it should be discussed anyway, as to what comes first. What's the algorithm with regard to certain, you started to talk about it, but what's the algorithm with regard to which comes first, the surgery or the biologic? And I must say that an important thing that one has to talk about is the insurance company, because they're the ones that usually make the decision. I have a patient now that has AERD and nasal polyps, and we've done very well with Xhans, using Xhans, and control. The problem is that she's going to get this taxes, and she really doesn't want to use, and she's never had surgery. She doesn't really want to use the intranasal steroid anymore because her nose bleeds all the time. So we tried to get her a biologic, and the insurance company say, well, she hasn't had surgery, so she's not eligible for biologic. I don't know, I imagine this varies from one insurance company to another, but I'm just pointing it out. I think these insurance companies are influencing
I think this is an evolving area, Mike. I think that further guidance is going to come out regarding this, and we're going to have to have consensus statements that tell you which ones, but we probably need a bit more data. It's getting late, everyone, so we want to thank you all for participating this evening. We can hang around here, but feel free to go. But I think it's been a great discussion. I think we've learned a lot about the commonality of the upper airways, the lower airways, and the importance of trying to identify what type of inflammation is going on, and how novel therapies can offer a lot of advantages in the management of our patients, reducing need for surgery, and reducing the burden for our patients. So thank you guys so much for coming this evening. And if anybody wants to come up, we're happy to answer any questions you have.
And the offer for the disco party is also still on.
Oh, yeah.
Mike.